New York City is the epicenter of the COVID-19 pandemic in the United States, and the city has the most number of cases of anywhere in the world. In today's episode of Life Prescription, we talk to a New York City doctor on the front lines working in one of America's hardest hit hospitals. Just a warning, this video does delve into some emotionally heavy topics. You can click the description below to jump to different sections of this video. I've also put links in the description of two related videos. One is all about advanced care planning and the other is advice on good mental health practices from a psychiatrist. If you find this video helpful, please make sure to share it with your friends and family. And please make sure to click the like button as it will help other people find this video. Welcome everyone to another episode of Life Prescription. I hope you're staying safe. I hope you're staying well. I hope you're staying inside. As many of you know, New York City is the epicenter of the COVID-19 pandemic in the United States, and it also has the most number of cases anywhere in the world. What healthcare workers and their patients are going through there are a once-in-a-century type of experience. And because of that, we are very lucky to have today's guest, Dr. Derek Moriyama, who is a New York City doctor working on the front lines of this COVID-19 pandemic. Derek, we're happy to have you on because we want to know what your experience is being on the front lines, going through all of this. So thank you for joining us today.
Yeah, thanks, Sri. I'm actually a longtime viewer, first-time contributor, so this is exciting for me as you take your drink there. But exciting to be here. You know, the viewers may not know, but we went to med school together. So we go way back, and I think a lot of what we learned in med school is, you know, the cornerstone of our careers. So I appreciate you being there for me during that time.
Thank you. Thank you for saying that. Derek is a very good friend of mine. We've known each other for many, many years. And it's actually pretty interesting to see how our class has done. We're all over the country. We're in different specialties. And a lot of our class is in New York. And we're going to be speaking to a lot of those people on the channel, and we're going to get their perspectives. And yeah, I mean, I really feel for you guys.
Yeah, I mean, it's been a crazy time, I think, for all of us that are working in the hospital. You know, we came to New York just mainly to experience the city, and so it's really interesting to see how much it's shut down and all the things that you usually enjoy about living in the city. It's sort of has not been there for the last month. Obviously, we're staying busy because we're working in the hospital. And so, but it really has drastically changed the city itself. So,
yeah, I can only imagine. When I was picking where to go for my training, it was between Los Angeles and New York. And so there was a very real chance I could have been there with you guys. But just hearing the stories that you've been through, hearing how your city's locked down, it's very hard. Like for me to hear what you guys are going through. So how has it been? How are you, first of all? How are you in your apartment? How are you handling the lockdown?
Yeah, I think for me, we've just been, you know, my partner and I have just been staying busy. There's a lot of work to be done at the hospital, and then outside of that in terms of research and that sort of stuff. And so I found it much easier to just continue working and to continue doing what I would normally do. And I think that's been helpful for me in terms of coping with everything that's going on. The hospital itself has just been, it's like nothing I've ever seen before. When I was a resident here just, you know, around a year ago, when I was in the ICU, we'd maybe had, I don't know, like 15 to 20 patients at max. And now the ICU is full of over 100 patients that are all ventilated with COVID-19. And so you're really seeing a lot of the house staff sort of stepping up and taking a bigger role in managing some of these patients. I think they were doing a really, really good job here. But really, I mean, the hospital itself, we're opening up new teams and and there's people from all different specialties coming to help. There's nurses from all across the world that are coming to help, across the nation rather. You know, a lot of nurses from the South, from the middle, or from the Midwest, not the Middle East, but
Right.
From the Midwest. And so it's really interesting to see how much everyone's come together to really try to help those that are infected with the disease and who are really suffering from it.
Yeah, and as you're saying, you have had a unique training experience. You've been part of the teams of almost every part of the hospital. You've been in the emergency department, you've been in the ICU, you've been on the wards, and now you're doing your palliative care training. So I'm very curious to see what your perspective is on this pandemic, on treating people on a mass scale from the perspective of a palliative care doctor. So before we get into that, Derek, I want to ask you, what is a typical day like for you in the hospital right now?
So I guess I can talk a little bit about what I would normally do, um, if that works a little bit better, and then I can see how that's changed. Does that
That's
work?
great. Yeah, we can see
Um,
what a typical day for you was like not too long
yeah,
ago, and how does that compare to now?
yeah, because I think so in palliative care, I like to say that we're the sort of the specialty that focuses on quality of life. And generally, we see the sickest patients in the hospital. And so those are generally patients with advanced cancers, with advanced heart and lung disease. And what we do is help them achieve a quality of life that they would want. So a lot of times that ends up being treating things like pain, nausea, and vomiting, especially with cancer patients. But we also talk about things like how patients are doing emotionally. If they're struggling with anxiety, depression, or the thought of that they have limited amount of time left, and helping them through that. So in general, when we consult for patients in the hospital, it's for patients that are have some sort of chronic underlying disease, and we're trying to figure out what the best next step for their care is. And this pandemic has changed the way that we look, or that we're treating patients in our workflow in the hospital. Namely because I think normally we have a lot of time to sit down and discuss things like how a patient's doing at home, and sort of a patient with cancer, they're going to progress over the course of months, and this has really shifted the timeline up so that patients are getting very sick very quickly.
Mm.
And so now my normal day consists of coming into the hospital, touching base with my team. There's now, normally the palliative care team maybe has 30 patients max. We're up to like 80 or 90 patients that we're seeing, and those are extremely sick patients. And so we touch base with this as a team, and we all go down to the ICU, and we make rounds with the ICU team, the intensive care teams, and really go through a lot of the different patients that they have, that they're worried about, that are imminently dying within the next 24 to 48 hours. And what we do is we round with them, and then we end up making a lot of phone calls to families to see how they're coping with the disease, or they're coping at home, and to update their patients' families on how their loved ones are doing in the hospital. And a lot of that comes down to sort of hoping with them, but at the same time giving them realistic expectations, which can be difficult, especially when they weren't expecting their loved one to be in this situation.
Of course.
So, and then after rounding with the ICU teams, we generally touch base with the general medicine team to see if they have any patients that they want us to see. What I've noticed during the pandemic is that we're seeing a lot of patients on the floors that are coming in with COVID, but they have a lot of comorbidities at baseline. And so we're having discussions with them that if the COVID gets worse and they need mechanical ventilation, is that something that they would want to pursue? So for example, I had a lady who we were seeing in palliative care clinic for the last 6 months or so, and she came in and she had COVID and her breathing was getting worse, and she had a lot of other comorbidities. So I had a long discussion with her and her family, and the decision was made to make her comfortable and treat her pain and her shortness of breath, and allow her to die peacefully, as opposed to escalating her care, knowing very well that the chances of her coming off of a ventilator, giving her underlying disease, was near zero. And so it was. So we're seeing a lot of those patients that are chronically ill and coming in with COVID, and we're having those difficult discussions with them. So those are the two major populations we're seeing. We're also seeing just general people coming in with cancer that would normally come into the hospital, without COVID and having other issues, and we're also seeing those patients as well. Yeah.
So this set of unique circumstances, once in a century type of circumstances, has really changed how you practice day to day. Where before all of this, you're seeing the sickest patients, as you're talking about, and you're trying to help them prioritize what's important to them, trying to develop a relationship over time, asking very, very challenging questions like, what is your quality of life? How do you want to be treated in the case that you get extremely sick? Do you want to be put on life support? Do you want to choose a path of just treating your symptoms and a comfort-focused treatment? And as you mentioned, those are things that you do over time. People who have advanced cancers, who have advanced medical conditions that are going to shorten their life expectancy. But now, as you're saying, you went from a daily census, a daily number of patients of about 30 to more than triple that. And you're rounding in the intensive care unit, you're seeing these sick patients, and it sounds like the intensive care team is asking you to prioritize those who they think are imminently dying, going to die in the next day or 2 days, or who don't have a very good expected course. And besides that, you're also going to the floor, which are patients who are not in the intensive care unit, but talking to people who may have to be escalated to the intensive care. So you're helping guide these types of conversations. So you're kind of like the doctor's doctor. You're helping kind of guide these discussions for the patients, but you're also at the same time like a patient liaison. You're helping them understand what they're facing, these questions about mortality that they're facing.
Yeah, I think you probably said a lot better than I did.
No, I'm just trying to summarize for myself.
That's a great summary.
Yeah.
I mean, listen, that was a great summary. Yeah, I agree with everything you said.
Yeah, there's a lot of changes that we're all experiencing. Obviously, day-to-day life is completely upended for all of us. And so one part of why one part is I'm just happy to reconnect with you as a friend.
Yeah,
it's been a long time.
It's been a good time.
Yeah,
you got to see my dog and everything.
Yeah, and two, this isn't going away for the foreseeable future, and so we're everywhere around the world is at risk for resurgences in COVID. Even if we flatten the curve in a majority of the world, or majority of the parts of this country, and so. Besides curiosity of catching up with my friend and seeing what your professional experience has been, there are lessons that I want to learn from you in case that we have to deal with these things over in Los Angeles. So, for example, in the news, hearing about healthcare workers everywhere and about unimaginable amounts of illness, right? Whole hospitals, like you're saying, turning into COVID-19 ICUs. And I saw in the news just yesterday, in a single day, 2,000 Americans died. That's beyond tragic to have that kind of loss of life on that kind of scale. It's not really something I can personally comprehend. I can't imagine 2,000 people dying. Of course, I've been in situations where patients have died, and a bad day would be 1 to 2 patients a day dying in the ICU. And now, I mean, across the country, thousands. As you're telling us, you're not a stranger to any of these kinds of difficult situations involving life and death, pain and mortality. That's your job. That's literally in your job description. So you hinted at it, and when you were talking about it last, about how this has changed your job description, or how this has changed your day-to-day life. But I want to get into that. I want people to get a view, not just these abstract numbers of thousands of people dying, millions of people being infected, but I want to see what is it like for an individual to have to experience this, and what is it like for you as a palliative care doctor to be there as as the liaison for that patient, and as a guide for other doctors in designing the plan of care. So let's talk about that. How has your role as a palliative care doctor changed in these circumstances? What are some of the biggest things that you've noticed, and what are things that we can take away from your experience?
Yeah, so I think one of the biggest change that we're seeing is normally when patients are sick, we try to have sort of meetings with the patient and their families face-to-face with the teams, and really go over the intricacies of their care and and really get a sense of who they are and what ultimately the goal of their care is, what their treatment goals are. And because of the fact that our hospital is not allowing visitors because just for public health reasons and safety, our patients are completely alone in their, they're alone in their rooms, and that they're isolated from their families in a lot of ways. And so these conversations that we're having are, for patients in the ICU, for example, the conversations we're having are over the phone with their loved ones, right? And it's hard for, we try our best to give them a sense of what their loved one looks like, right? But unless they're there to really see what's going on, it's very difficult. And so I think has been very challenging with this sort of pandemic. I think the other thing is that we're just seeing so many more people, and a lot of these people are unfortunately dying. So like you said, I see death all the time, and that's, I take care of patients at the sort of end of their life. And even for me, it's a lot to take in. Just the other day at my census, I was following around 12 patients and came back, after a day off, and about half of my list was gone, which is very unusual, even for me. And so the sheer amount of death, I think, is different. It feels a lot different. Then the type of people that we're seeing in the ICU are not the typical patients that in palliative care that we normally see. And the reason I say that is because we usually see patients, again, with cancer, and they've sort of been getting worse and worse over months. It's the same thing with sort of heart failure, liver failure. These are people that are sick and they slowly decline over time. And now we're seeing patients that were walking around maybe a month ago working a normal job, providing for their family, and now they're in the ICU for a prolonged period of time. And so I think that's what's, I think the most difficult is that you're seeing a lot of fairly healthy people that are declining very quickly, and very sick very quickly. And so part of our job that's been challenging is communicating that with families, that their loved one is very sick, and that despite the fact that we're doing everything, they still might not make it out of the hospital. And in fact, the ones in the ICU, I feel that a majority of them won't make it out of the hospital. And so having that discussion with a family that's wasn't expecting this to happen is very difficult. And getting them to a place of sort of, helping them handle that grieving process has been extremely challenging, especially because you can't see them in person. You're doing most of this over the phone.
Yeah.
So you can imagine that it sort of changed the way that we're approaching patient care and sort of interaction with families.
That's one eye-opening, but one very painful to hear, that people who are experiencing basically the end of their life are potentially going through that alone, with minimal contact with their loved ones. And someone who's on the ventilator, someone who's on life support, isn't going to be able to communicate anyway. So when you're talking to their loved ones, you're just showing them a video of how their loved one is doing. But as you're mentioning, usually you are seeing patients who may not be a surprise that they're getting worse or getting sicker, people with cancer or severe heart disease or liver disease. But these are people, or at least some of the people you're seeing, may not have been expected to be this sick, people in their 40s or 50s, 60s, without that many medical conditions. And so that being alone, having this unexpected change and be just completely blindsided with how sick they are, that's got to be obviously very, very challenging for you personally as a palliative care doctor, to try to provide some comfort to the patient, to the patient's families about how they're doing, because that's a large part of your job, is to be there with your patients as they go through this experience.
Yeah, and I think going back to I think palliative care over the last 5 years has done a really good job of moving our practice to patients that we know are going to get sicker, for example, with cancer, but aren't at that point yet. And I think we're able to have these conversations about death and dying and mortality over a longer period of time. So, I had a patient in clinic that I was seeing for 3 or 4 months, and I was, I eased into the conversation to the point where towards the end of his life, he felt very comfortable with discussing these sorts of things and things that he would and wouldn't want. But that took a lot of work on my part to introduce that subject and sort of and work on it over time. And now we're seeing patients coming in, and we don't have the luxury of that time of forming that relationship with them and really getting a sense of who they are and how they view death. And so I think that's also been a huge challenge of patients coming in, and they're decompensating very quickly, and everything it feels like it's going so much quicker than we're used to seeing. So.
One analogy that you used before I hit the record button was, it's like a car crash. One day your loved one is doing fine, then they get mild illness like fever, cough, shortness of breath, then all of a sudden they're in the ICU and you can't visit them. I want you to explain that analogy. I thought it was perfect, the perfect way to describe what people are experiencing.
Yeah, I think when we take care of patients in the hospital, that's generally patients that are normally well, and there's a tragedy like a car accident or getting hit by a car, and they come into the ICU. That's a small proportion of patients that we normally see. And now imagine most of the unit is like that. Most of, around 100 patients are like that, where they were functioning normally, and then all of a sudden they're in the ICU. And again, it's like they were walking down the street and got hit by a car, except for we're seeing hundreds of those, coming into the hospital. And so normally, having that conversation is difficult with families that are that have had that happen, where they're not expecting that they're going to be in the ICU. And now we're seeing large numbers and having a lot of those conversations. And I think that's sort of been one of the hardest parts about this, is it's a difficult conversation regardless of what specialty you're in, and having to relive that pretty much on an hourly basis, talking to these families that are telling me, my father hasn't missed a day of work in 9 years and he supports my whole family. Normally we don't, we see that I would say infrequently, and now it's by far, in a way, the most common thing that we're seeing.
Wow. On a personal level, seeing that kind of tragedy, as you're saying, like hourly, basically, how is that affecting you?
Listen, I think, I try my best to sort of deal with it. And I think my philosophy on death is probably different than a lot of the people that are, at least in the United States. And for me, it's a constant reminder of how good my life is, and that how, fleeting this world is. And so because of the fact that I'm having to see these patients that were seemingly normal just a month ago, and how severe the disease is, really gives me perspective on what kind of things I want to get out of my life, and the important things, and not dwelling on these, insignificant little things that make me anxious or upset. And so that's what I have found has, that outlook has been helpful for me in dealing with all of this, because at the end of the day, the amount of death that we're seeing is quite difficult. And I think we are going to have to unpack it after all of this is, hopefully over, because I think we're going to have a lot of people in the hospital that are, going to have issues with just the numbers of sick patients that we're seeing, and the inability to really do anything other than prolong their life in the ICU. Yeah.
So it sounds like seeing what's happening around you, seeing what's happening in the hospital, is almost like eye-opening. It's showing you that your own life is fragile. Obviously, I hope your life is, long and happy on a robust, on a average human scale. But at the same time, you're seeing people dying daily, hourly, almost, it sounds like. And so, but that is kind of refocusing your own life perspective, what you value and what is important to you. And so I'm very curious, actually. So what did you mean by how we view death? How do you think we view death? How do you think our society views death? And what are your thoughts on that?
Yeah, so that's a good question. I think the pandemic has really shed a light into terms of how we as a society view death. Um, just because the sheer number of people that we're seeing and calling families and getting a perspective, um, I think that we have an issue with not discussing death in our society. And so when we look at sort of Buddhist cultures and some sort of East Asian cultures, um, they the they look at death in I think a little bit of a different way. And so I went to my grandfather's funeral maybe 6 months ago, and he was Buddhist, and the Buddhist monk had said something really beautiful at the funeral. He said, what makes life so amazing and so um, spectacular is the fact that it's so fleeting, right? That fleeting aspect of it, the finite period of time that makes it beautiful. If you lived for an infinite amount of time, would you really appreciate that sunset, or would you appreciate, taking your dog for a walk? And so I think that if we can normalize that discussion about death in our society, and make it so that it's not such a morbid thing to talk about or something that's scary to talk about, but something that's sort of normal and something that's unfortunately going to come to for all of us at some point. If we can normalize that discussion and really start thinking about death, then I think we can help teach us to appreciate the really small things in life. So the fact that you can use your hands to wash dishes, right? Normally it's something that pisses people off, but if you're able to use that as a almost like a miracle in life that you're able to do that task, you can really enjoy it. And I think that's something that in Buddhism that they get really, that they do really well, is sort of having that appreciation for living in the now, as opposed to dwelling on the things that could be in the future or things that have happened in the past. And so I think, for me personally, I think the first step to opening up that discussion is to having an idea of things that you enjoy doing in life and that make life worth living to you. And that helps us tremendously as clinicians in the hospital, because if I know someone really likes to watch football and that they enjoy sitting with their grandkids and watching football on Sunday, and if they couldn't do that and they were in a nursing facility and they weren't able to conceptualize what football is, that's important, because I think having that idea that they really appreciate those things in life and that they may not want to live a life where they weren't able to appreciate those things makes our decisions about, whether to pursue that chemotherapy or that ventilator or that doing CPR, that's really helpful for us to make those decisions and to help guide families. But unless you have a discussion with your family and your loved ones about things that you really cherish in life and that make life really worth living, we can't really have those discussions if something were to happen. And so I think the other thing that this pandemic has shed light to is that people that we normally think are have low likelihood of getting, being in a situation where they're on a ventilator in the ICU. It's sort of increased the number of people that's happening to. And so I think having discussions now is helpful, just in case, in the event that it were to happen to you. I think an easy thing for a lot of people to do at home is to at least, I view it as a low-hanging fruit, but have a discussion with your friends and your family about who you would want to make decisions in the event of an emergency, because that makes things a lot easier for us to go to someone that you trust and that you have designated to make those decisions for you in the event that you can't make decisions. I think that's an easy first step in terms of pushing the conversation about death along in this country.
Derek, that was beautiful. I really, really love that. The explanation of the Buddhist philosophy of how life is fleeting, how life is fleeting actually makes life more precious, and being able to enjoy little things like I'm able to move my hands around right now. The fact that I have working hands should be enough for me to be happy right now. Yeah. And I think you're right in seeing the economic pain, seeing the loss of life is really refocusing what we as a society, or at least it's an opportunity for us to refocus what we think is important. And so being able to appreciate life right now is something that, like, very actionable that you've given us, is thinking about how good we have it in our lives, appreciating the little things, but also being open with our own mortalities. On a day-to-day basis, sure, I don't think I'm going to get sick, but as you're mentioning, we're going to the hospital, we're seeing these COVID-19 patients. There is a chance that one of us could get sick. So living our lives, knowing that our lives are finite, and appreciating the little things is something I'm really going to take away from this. And then the other thing that you mentioned, which is very, very actionable for everybody, our listeners, every single person who is interacting with this content, is to talk to your families about your wishes. Basically, what would happen in the case that you go through a sickness or an illness, or have to go to the hospital for whatever reason. What are the things that you care about? What are the things you value? What is your minimal acceptable quality of life? Would you want to spend the rest of your life in a nursing home, not being able to communicate? Would you want to be on life support? Those are very difficult decisions, and require deep introspection, and require you to really talk to your family members in a way that most people probably haven't. And so I really encourage everybody to talk to their families, listen to Dr. Moriyama here, think about, like, yes, we don't want to be fear mongers. We don't want to scare people into thinking that, the whole world is burning. The truth of the matter is, from the data out of China and the most preliminary data out of New York, is the vast majority of people are going to be fine. 80 to 90% of people won't ever even need to go to the hospital. But at the same time, with the sheer numbers of people who are getting infected, there are going to be a lot of people who are facing this. And a lot of those people, if it's not you personally, it may be a loved one. And so knowing what your loved ones value in their life, I think, is something that I'm going to take away from talking to you today, Derek.
Yeah, I'm glad I could help out. Like I said, I think it's from this pandemic, I've realized how beautiful the medical community is. That's another takeaway that I've sort of, in terms of how hard these people are working and really risking what they have to help others, has been an extremely heartwarming thing to experience. So I think taking away those little things can really help, can go a long way in terms of your happiness and lowering your anxiety. But yeah, I appreciate you having me on this show.
Yeah, no, I appreciate you taking the time to speak with us. I know you have very limited time off. You're extremely busy. Your hospital is basically bursting at the seams. So we're just happy that you're safe, that you're doing well, and that we get the chance to learn from you.
Yeah, it was good to be able to catch up too.
Yeah, definitely.
You're looking good. You're looking younger than when I last saw you.
Yeah, I get it from my father. That's
okay.
Yeah. It's good genetics. Yeah. Somehow this hairline is maintained itself.
You got a good hairline.
I don't know how or what secret. There's no secret.
You look kind of like Hassan Minaj's hair there.
Yeah, like his kind of shorter cousin who kind of let go a little. I got the COVID-19 pounds is what.
Well, you got to shave this for your when you wear the N95.
Yeah, I'm actually off work for a little bit, so if I got to go in, I'll do an emergency shave. I keep a razor in the car in case.
All right. Yeah, good. Yeah, you always got to have the emergency shave.
And I actually had one of the residents buzz my hair.
It looks good, actually.
Yeah, he because we're on the COVID unit together, so I figured we don't need to isolate. So
yeah, it looks great.
I haven't had a haircut in a while. And I didn't touch the top, but he just buzzed me on the side. So at least I get, N95 doesn't go there, but. So, Derek, it was good talking to you.
Yeah, likewise. I was happy to hear from you, and I'm glad to see that you're doing well, and hopefully I continue to stay healthy.
Thanks again, Derek.
Yeah, thank you.
Hey, if you're here at the end of this video, thank you for sticking around. If you don't mind, I want to ask you for some help. I'm trying to plan out what I'll be talking about in future videos, and I want to know what you think I should be covering. Let me know your thoughts or questions in the comments section below. Thank you for continuing to learn with me as we navigate these uncertain times together. Until next time, stay safe, stay well, and I will see you soon.